Thanks everyone for coming to our Reza and my pre-interview talk. We both appreciate all the feedback and suggestions. I have no disclosures. Brief outline of some of the things I'll be talking about. The first project is something I'm doing with Dr. Jackler and Dr. Damrose about overlapping and concurrent surgeries. It doesn't start here, but I will just, for the purpose of my background, I'll start with this October 2015 Boston Globe Spotlight report. It was this like 14,000 word investigative expose about the topic of overlapping surgeries at Mass General. It's definitely worth a read. It's like filled with drama and like big egos and patient, fortunately, complications and high stakes, and it's a good read. What it did is it sort of shed some light on the practice of a single surgeon having a patient in more than one operating room at the same time, which to a lot of people in the public that sounds kind of very unusual. So it did lead to some public and government outcry, including an ongoing Senate Finance Committee investigation. Sort of in response to this, over the past year, hospitals and surgical societies and medical experts have sort of been reacting and publishing opinion pieces and guidelines and stuff like that, various viewpoints, and JAMA and the American College of Surgeons has issued sort of guidelines as to how surgeons can address this with the public and with their patients. And some medical centers have even gone as far as basically making, requiring one-to-one surgeon to operating room ratios, which is a new policy for some. Just some brief definitions. The American College of Surgeons. Operating room time, I think we can all very easily conceptualize as the time a patient enters an OR until the time they leave the OR. It includes basically everything from patient positioning to anesthesia time, starting lines, intubating, prepping, draping, everything like that. And this is pretty easily determined because the nurses can just check a time in and check a time out. Overlapping surgery is defined as any overlapping procedural time when the surgeon is working on the patient. This is, again, skin to skin is the traditional definition. This is harder and, sinus surgery or laryngoscopy or like a drug-induced sleep endoscopy. That's a little harder to measure per se, but again, in most records, the nurses can mark when a procedure begins and ends, so it's kind of easier to determine. Concurrency is defined as any overlapping critical portion of a procedure. So if there are two patients with the same attending physician in rooms next door, if that critical portion, getting the lesion off the vital structure, getting the margin around the tumor, reconstructing, the microvascular reanastomosis, these differ by patient, they differ by procedure, and really only the surgeon can truthfully tell us or determine what that is, because they do change on a case-by-case basis. So that's much harder to determine. A few considerations. Why is this important? Like obviously, the public doesn't want to hear about you having more than one patient at the same time, but does it really matter? There are some considerations. Ethically, how much right or what do we have to tell our patients as far as consenting them and informing them that, you might have multiple procedures going on at the same time? Do you have an obligation to talk to them about that? And there's, some debate as to how much patients deserve to know and should know. And, typically, being open is always better, but, even some patients knowing that a resident is going to be in their room, even though it's on the consent form and it's kind of implied if you come to an academic institution. For some, that's kind of a bigger leap of faith than for others. There are financial considerations, being able to have, two procedures going on at the same time, can actually increase a surgeon's productivity. It can decrease wait times for patients, for, long wait times for sinus surgery over at the VA, because we can do like 1 or 2 procedures a week versus doing, 4 or 5 in multiple rooms. There are variable financial implications for hospitals. In some cases, they can actually make money by having overlapping surgeries, and in other cases, it's a wash, or it can actually be a money loser because of increased anesthesia time, or there's other logistical issues here. I think the big point is the potential for double charging, and this is actually why the Senate Finance Committee looks into this and is the government agency that's really looking into this. Insurance is paying an attending surgeon to, based on a procedure code, to, be in an OR and do a procedure, and specifically the critical portion of that procedure is what they're getting paid for, in addition to, the academic institutions, training residents and fellows. If if there were, and if this doesn't happen at our institution, but if other places, if there were 2 rooms going on at once and a resident or fellow were doing the entire surgery, the critical portion of the procedure, Medicare is already paying our salaries, so insurance would actually see paying both the resident's salary and a surgeon fee that might constitute fraud. So that's a reason that this is kind of a big deal from a government standpoint. And then of course we're interested in outcomes, if they're equivalent between overlapping and non-overlapping surgeries, and then safety. Is there any increased OR anesthesia time, and is that associated with increased risk for patients? And are there any, again, procedural safety or increased complication risks? There aren't a lot of actual great studies on this subject. There are a lot of opinion pieces and a lot of anecdotal evidence. Over the past year, though, there have been 3 sort of abstracts that have been, or papers that have been presented at some national meetings, all various retrospective chart reviews in cardiothoracic surgery, neurosurgery, and orthopedic academy meetings. All sort of found the same thing. They've compared overlapping and non-overlapping cases, not huge differences. And the first one was the cardiothoracic surgery study from the University of Virginia. They found there was no difference in OR time, morbidity, or mortality in overlapping and non-overlapping cases. It should be noted that all the residents in their program are board certified general surgeons. So basically all of those cases had at least 2 attending level people in the room, if that makes any difference. In the neurosurgery literature, again, very similarly, they looked at, there was no difference in overall serious or life-threatening complications. It should be noted, though, they only looked at 1 single experienced surgeon out of 5 in their group, and that was a study out of Utah. And in the orthopedic literature, it's shown that there's no difference in OR time, procedure time, and 30-day complication rates, which really they're just looking at unexpected admissions and reoperation. But this was only looking at an outpatient surgery center, so typically very young and healthy patients. So we have designed as a retrospective case control study looking at our department's QI data, which we have gathered not only through Epic, but basically from our submissions at our monthly M&M meetings, and then the OR case tracking data. Our primary outcome that we're looking at is overall complication rate, but we can also look at sort of serious life-threatening or life-ending surgical complications, as well as OR time, unexpected admissions, and reoperations. Secondary measures to look at is surgery categories, so sinus surgery versus laryngoscopy versus drug-induced sleep endoscopy. We can look at surgery length, patient BMI, SA grade, blood loss, booking latency time. So that would be when the patient shows up and a booking form is filled out to when they're actually in the OR. So someone comes in with a really bad lesion at head and neck clinic on Monday, and they get added on later that week. Does that change the patient's risk profile versus somebody who was booked 6 months in advance and had a lot of planning and was put as an overlapping case because it's a relatively straightforward thing. We're doing univariate analysis to compare total versus no complications. Looking at overlapping and non-overlapping cases and the total number of complications, and then some univariate regression analysis to look at some of these additional confounding factors. Again, we don't have all the analysis done yet. I'm just looking at some raw numbers right now. Where do you think our department ranks, in terms of overlapping surgery in our hospital? Any thoughts? Number 2. That's a good guess. We are actually number 6. That's us right here. So this is data just from the past 12 months I pulled up. This is overlapping skin-to-skin surgery time. These are basically all the specialties here. This is the percent overlapping. The size of the circle indicates sort of the number of cases. So our department, that's about 2,600 cases, and 16% or so of them, there's some procedural overlap. So we're right there, kind of around neurosurgery and cardiac. Orthopedics is our biggest. They have, that's like 5,000, 6,000 cases. They have about 16% overlapping, 17% overlapping. Interestingly, hand surgery, which is only like 600 cases over the past year, they're up to like 36% overlap. But they have a lot of a lot of those are like reductions in the OR and tendon releases, so there's the time overlapping that's really, really small in those cases.
So, at Stanford, are the OR nurses clocking when the surgeon comes in and out, or are you just looking at the total time of the case?
This is just time of the case.
Right, we don't have, not yet, that's been proposed, is that they need to, there is a proposal on the table that they will clock us in and out.
I think more recently they have been tracking like when surgeons and even residents walk in and out of the room. It's not always up to date though, or sometimes they'll like mark it at the beginning of the case. So it's not reliable data, and I don't know if that goes, I mean, most of the data we have goes back to 2008 when we really started tracking this.
So you're just looking at basically overlapping without
This is
any
it.
reference to what are the key portions of the surgery?
That is what we are looking at, yeah, because we found it retrospectively very difficult to look and track what is a critical portion of cases. So right now we're just looking at procedural overlap, skin to skin time. That's all we are looking at. If we were to do a prospective study, I think it would be easier, not easier, but I think it would be more reasonable to do that. But I think right now it would be almost impossible to look at.
Yeah, I don't think that is there.
And truthfully, I mean, there's more to this in that, like, our data, neurosurgery, there's a lot of the cases that are sort of, there's overlap, a lot of them are double booked, not double booked, a lot of them are cases where, again, we are working with neurosurgery, so like our transphenoidals and our, some of our skull-based cases, there'll be, an attending will have a patient in multiple rooms, but they will, there's multiple attendings responsible for that patient, and some of that data is not captured in just these raw.
So I'm still not clear on the concept. You have one attending man going between two rooms, supervising the residents, or does that also imply a head and neck case with a plastic reconstruction going on at the same time?
Some of it will be that, yeah. So there will be.
But they're two separate issues. You've got two separate operations going on by two separate services, two separate doctors. How can you lump them together?
Well, we can break them apart. So we can look at like surgery. We can look at surgery category and surgery type, and we can look at how many attendings are booked on that same case. So we can break it up. I mean, right now I'm just looking at everything, but we have the data. So we have, again, it's a joint. Even within our own department, I mean, it could be Dr. Holsinger doing a resection, and then Dr. Dibley coming in to do the reconstruction, and then Dr. Holsinger having a second case going on. I mean, that would constitute. Just under these numbers, that would constitute an overlapping procedure.
Right.
But we can tease that out a little bit more.
I see.
In some of the more recent data, it's harder to do going all the way back to 2008, but in some of the more recent cases, it's easier to actually tease out when one portion of a procedure, one panel ends and another one.
I see. Thank you.
Yeah.
I think just, for your data to actually be useful, you'll probably better to just limit the cases where ordinarily only one team will be serving.
I mean, that's
Because that's really what the issue is that was brought up. It was a surgeon that's doing the case that usually a surgeon would do, one surgeon would do for one patient. But multiple patients at the same time.
I agree, and that's a lot easier to actually look at and analyze, and that's what most of the other studies, the cardiothoracic and the neurosurgery cases have all done. So they've excluded all those other cases.
So how come you have cardiac surgery, cardiac, thoracic, and cardiothoracic? Those are four different paths.
Yeah, cardiac it's lumped in here because a lot of that is like interventional cardiology.
So you're going to need to specify, because it looks like you're saying sort of
This is the way the OR categorizes surgery. So I just kept it like that. But yeah, cardiac. That's a lot of valve replacement. That'll be like intravascular valve replacements, cardiac biopsies.
in that case, you also have interventional radiology.
True, and again, that would be it's just the way that it's coded. The department coding is, but we can certainly lump that all together. Not necessarily important for everybody.
Yeah, I'd suggest you clean that up.
Fair enough. Just again, the QI data that we have, just from about the same time that we have this overlapping data, there's about 460 like individual QI submissions that have been made. So that's sort of what we have submitted. There's obviously some bias, and we are missing a lot of cases because not everything or not every complication gets recorded. So we additionally have to go back and look at 30-day readmission rates that might not always get reported at QI conference. And there's a lot of these are not necessarily surgical errors. Some could be medication administration errors or anaphylactic reactions on the floor. So they're not all surgical complications. And then over this 7, 8 year period, we have about 16,000 cases total. Our department is about 12% with some procedural overlap, and 10 of our surgeons or so are about over 5%, or what right now being defined as like high volume health plan things. So we wanted to break it down more and just look at specific high volume overlapping surgeons. Any other questions or comments on this project?
It's a big project. Good luck.
Sorry, what was specifically is your guys' question, or?
The question is there an increased rate of complications, readmissions, or reoperations in cases that are with procedural overlap versus those without procedural overlap?
Complications you're measuring just by QI.
That is one way, yeah.
Is there another way? Are you guys thinking of
I mean, no, it's mostly QI, but again, there's some things that aren't captured just in the QI, so also just going through those charts again.
Just because the number, just wondering because the number of cases you're dealing with and the number of submissions is pretty, you're gonna have a hard time probably finding.
Yeah, and I mean, one of the issues is whether,
It's huge.
whether the study is powered enough, because if we look at all complications, and if you really actually want to make a statistically significant argument, you need to have enough cases of and complications of like the most rare complication in order to statistically power the entire study. We know that's a limitation of sort of the data sets that we have. I think as a first step, though, we are looking very, very broadly. I think the one unique thing about our study comparing to the other ones in cardiothoracic neurosurgery and ortho literature is that while it's limited data, we do have this QI database that a lot of other people don't have. So they just look at readmission and reoperation and like OR time for the most part. So even if we just narrow this down to specific sets of cases, I think that gives us something a little bit more unique. But there's a lot of paring down, I think, that we have to do. It's just preliminary statements that we need to make something in this.
That's ambitious.
Could you look at the opposite and compare cases that do have procedural overlap versus cases that don't, and then just try to see the difference in complication rate between those? That seems like more.
Yes, yeah, and that's what most of the other centers and studies have done, basically.
So you're not bothering doing that again for ours?
We have thrown it back and forth, and we have debated both ways. So that was a consideration.
I would think that the problem of complications that are significant enough to hit QI would be awfully small.
Yeah, it's
Yeah. To be
looking
able
through
to
the data. I
compare.
mean, you see the huge difference. I mean, there's some very minor things that go in, and they're really big ones. I mean, just going through the charts, the things that actually, the complications that I have found that haven't been submitted for QI, and there's a huge disparity there. So I mean, it's incomplete and it is biased data. There's definitely holes in it, but it's sort of where we started, and I think that we are going to eventually move more in that direction, especially now that we're actually looking at the numbers and seeing that it's not great.
So is there an alternate way of looking at complications, like charts are abstracted by the other?
Sorry, remember that?
Is there a different way of accounting for complications that's not just QI? Because I agree. I mean, for scientists to say, well, CSF leak would get presented, but postoperative staxis might not. But if you look at sort of what do people think the complication rate of FES is, maybe 10% when you include all those things, and then major complications is 1%.
Yeah.
So immediately, then, if you say my baseline is 1% major complications, to power your study, it becomes a rare event, and then
Yeah, and we're looking at that too.
Whereas minor complications may still be qualitatively important for a patient experience and may not be captured. So if there's another way that charts are abstracted by independent people when they're coding for hospital-based curious is maybe there's a different way that you can count.
Yeah, and part of it is most of the outside data, most of the other studies are small frames. So the people that we've been working with, Dr. Jackler and some of the people in the OR administration, they wanted to look at this long period of time that we have because we've been collecting this data for so long. So the sheer number makes it harder to do that, but complication rates in our field is also very low. So like DVT rate in our ENT is so much lower than in cardiothoracic and ortho and neurosurgery. So that's
So
the
you
numbers.
are you also
complication
looking
rate
at the
low.
time of the procedures though?
Pardon me?
The length of time of the procedures? Are you looking at that?
The total time?
Right,
Yeah, we have that data as well.
to compare concurrent versus?
We can, yeah. That's one of the things that we're going to potentially look at is time, actual OR time by procedure.
I think if you limit it to like single surgeon cases and overlap, it's probably, the data will be more useful, and then the numbers won't be as daunting. You could actually go through the charts and actually pick a granular
Yeah.
from there.
I think ultimately what we're going to do is probably end up looking at our highest overlapping surgeons as a subset of our department. And those cases, the numbers will be more manageable and reasonable. That's probably what we're going to end up doing after we look at all this data right now.
And were you saying that to account for acuity or to control for acuity, the length of time?
No, I'm just saying that theoretically, if you are, if the attending surgeon's not in the room, the case may take longer.
I was thinking about the standpoint that higher acuity cases are more likely to be overlapping and more likely to have complications. Like all the head and neck cases that turn out, probably they're more likely to be overlapping. So you're going to have control for acuity somehow.
Yeah.
I think all the cases that we book with more than one surgeon are going to be more complicated and have more complications, right? I mean, all of our CSF leads are almost
Yeah.
by definition cases that we do with neurosurgery where there's going to be overlap.
So that
So my
really
thing
should
should
be
be-
almost like a separate study, is those with multi providers compared to what Uchi was saying, look at first the single provider, or, single attending surgeon versus the multi-attending surgeon, look at that data separately.
Yeah, you have
'Cause
to
I
look-
agree,
You have
those
to
are
look
gonna
at
be-
cases that don't require multiple surgeries, right?
Yeah.
Otherwise, you're not going to be able to compare those, those with overlap and those without.
Yeah, and that's why that neurosurgery study I referenced, they only used one of the 5 surgeons. It's because it was a surgeon who didn't work with any other types of cases that they were doing. I don't know the specifics, but they didn't actually have any cases with other services. So it was easier to look at that data.
I do like Zara's idea about comparing, like, per surgeon or per category of type of surgery, of overlapping and not, because, I run a lot of second rooms, but if you compare my complication rates to DL room, that's single, they may not be comparable, and you don't know that the baseline complication rate of all the cases that are run non-overlap actually is fundamentally different from kinds of cases that are being done jointly. You know what I mean? Because
Yeah.
we're using the specialty to say this is the complication rate for our specialty, but within the specialty there may be differences in the kinds
Yeah.
of cases that are being done.
Yeah. Totally agree. And we luckily have that data. I mean, we have everything by procedure code, so it's actually pretty easy to
Yeah.
tease most of that out. And it's great. The functional sinus surgery is going to be easier to compare than the complex skull-based case with multiple things and services.
You go back once. It's interesting just to look at, those cardiac orthopedics and neurosurgery are by far the most lucrative services for the hospital. I'd be interested to see about something aside thing is access to OR time and running 2 rooms. Is that, I don't know, the ability to run 2 rooms depending on how many block time you have.
Yeah. And a lot of those ortho cases, and they're very busy with the biggest circle there. A lot of them are done at the outpatient center across town. So at least a lot of the overlapping ones are. I'm working on a second project with Dr. Chang and Dr. Trong about pediatric bone conduction hearing aid use. So again, bone conduction devices are versatile options for unilateral or bilateral hearing loss. They provide both surgical and with headbands a non-surgical option. Sound quality, comfort, cosmesis, things like that remain a big issue in whether patients actually use these and derive benefit. So things that we think we know from the literature is that we can predict benefit that patients might have, adults might have with bone conduction. Headband trials before, not only are those predictive of benefit, but they're predictive of whether a patient will actually use them and compliant with them. There are no similar studies in children, so we don't really know whether delaying surgery for headband trials is worth it or not. We know that objective and subjective data they're not always congruent. Some of this has to do with, again, there are some in adults, especially cosmetic issues, or they don't like the quality of the sound, but they're still deriving benefit from it. And in some specific cohorts, compliance is as low as 50% after surgery. So what we wanted to ask is what factors influence, whether children with conductive hearing loss will derive clinical benefit and be compliant with their bone conduction devices before surgery. So we've designed a retrospective cohort study looking at our Packard audiology patient database. So there's about 160 patients that either have the Cochlear or the Oticon systems, and some of those patient numbers are overlapping if they switch from one to the other. It's over 150 patients. And we are going to look at the type and duration of hearing loss reason, age of onset, whether or not they use the headband and for how long, and we're going to measure, again, the compliance with the bone conduction device, objective audiometric data, and subjective improvement with patient questionnaires that have been validated in a lot of that have been used in adult literature and validated in pediatric literature. We're limited by response rate with all for the survey portion of it. We're going to be limited by the response rate. There might be some parent bias, or we're capturing again, we're surveying the parents and younger children, but potentially the patients and older children, and there's some confounding factors, syndromic children or those with developmental delays. Comments, questions?
Sorry, one question. How are you measuring the compliance with use of the device?
How are we measuring compliance? Well, we are, through their follow-up, we actually, most of these patients report whether they're using it.
So basically, you're just going to have whatever the patient told the clinician. So that's subject to a lot of recall bias.
Most hearing aids have logging data, right? Do Bahas have that?
I'm actually not.
I don't think so.
I haven't looked at that. I don't
I wonder
know.
why not. That's not a very esoteric thing.
Logging
Maybe,
data?
I think that may be in there, and we may just never use it. It'd be interesting
I
to
haven't
talk to
looked
the
at it, so I'm not
audiologist to
sure.
see if they can
Yeah, you could
access
ask. It's pretty routine when these kids come in to ask them, so are you wearing your hearing aid? And if so, for how many hours a day? And you get those that say, oh yeah, we're wearing it. How long? Oh, maybe 30 minutes a day? Stuff like
Yeah,
that.
that's
It's
the
pretty
kind of thing.
common.
For some of the younger kids, they come in with some of the audiologists will send them home, and the teachers will bring that. Teachers will fill out little forms, like whether they're actually using them in class or not. But yeah, a lot of it is just subjective. I don't
And
know
there's,
if it
yeah, but
tracks
there's a real striking difference between what people report and what the data logs
Right,
report also.
yeah.
So you may just want to check with the audiologist. I've never heard of data logging with these devices, but if it's available, you should use it.
Wow,
Yeah,
that's a
'cause that
great.
could make a big difference.
Working on another project with Dr. Seidel about pediatric tracheostomy practices. Again, trachs are a very common procedure, but the implementation and care for trachs varies by institution and even by practitioner within an institution. There's tons of literature on it, book chapters and opinions and observational studies, but not a lot of very high quality evidence. What evidence is there does support that multidisciplinary care for trachs and tracheostomy care protocols that have been implemented can decrease morbidity and mortality around trachs and significantly reduce the time to decannulation. A lot of these patients otherwise can kind of get lost in the fray, and sometimes they're never really put on a path towards decannulation. So in that light, the Academy in 2011 convened an expert panel that came up with a clinical consensus statement that had sort of recommendations, things that seem kind of, their general statements, all supplies to replace a trach tube should be at the bedside within reach. Like an 8 out of 9, a green score. One person rated it 7, but everyone else rated it 9. So again, these don't necessarily reflect physician practice, and they don't none of these really specifically address the pediatric population. Some of them are certainly applicable, but the entire study looked at both adult and pediatric trachs. So we were, again, planning to just describe baseline practice patterns for pediatric trachs. We designed a survey to administer through the American Society of Pediatric Otolaryngology, and we were planning just to look at the percentage of respondents employing sort of specific trach management protocols or, techniques based on some of those recommendations and other things that are commonly done. We're again limited by, it's a survey, response rate is going to be a huge issue, and there's only certain things that you can really gather from a survey, and there's a wide variety of training and practice backgrounds that is somewhat difficult to really tease, but there's really nothing in the literature about this. So I think it would be an interesting starting point from the pediatric standpoint.
What kind of things are you asking on the survey? You're asking about where do you put them, if in a step-down unit, that kind of stuff?
Yeah, some would be about actual procedural, but a lot of it is care afterwards. So who is responsible for, where does the patient go post-operatively? Did they go to a monitor bed or PICU or what? Who can actually care for the trach on the first couple of days? Who does the first trach change? Who's actually teaching parents? Decannulation protocols. Are all these patients getting an MDLB before decannulation to check for suprastomal granulation or whatnot? And so it's mostly actually about sort of care afterwards, I would say, and maybe some preoperative. There's some preoperative practice questions about family and patient teaching, whether that's actually done, whether speech pathology is involved preoperatively or postoperatively. But an actual surgical technique, there's a little bit less about that. Fewer questions about that. And then lastly, in the fall, I applied for the Stanford Biodesign program.
All right, after disclosure, these are projects. The two first projects are my big project, big gigs there, and then the next 3 projects. I'm just briefly talk about them. These are beautiful people. My mentor for the past 5 years, the past 2 years, the past 1 year, the past 6 months, and Dr. Mose did apologize. He had some family issues that he needed to attend. Dr. Patel is here, and Sammy on behalf of Dr. Mose. Dr. Dan was my mentor for my QI project. So first study is a randomized clinical trial about olfactory training for post-radiation olfactory loss of patient with perinatal simultaneous brachial carcinoma. So these are my mentors. Dr. Patel is the PI, and the rest of the people up there is going to be co-investigators. So a little background, NPC arises, as you all know, from the nasopharyngeal epithelium and tumor presents frequently at the fossa of Rosenmuller. Nice depiction there. And it does invade adjacent anatomical spaces or organs. And the current standard practice for this kind of tumor is actually IMRT, which stands for intensity modulated RT. With or without chemo is the current standard treatment for NPCs. On the other hand, silent nasal malignancies are uncommon, but important. Surgery and adjuvant radiotherapy, with or without chemotherapy, are also the mainstay of therapy for this group of tumors. So the idea for this study came from this paper, which was published in 2012, which actually studies, they did study the olfactory bulb actual volume in the patient who underwent nasopharyngeal, patient with nasopharyngeal cancer who underwent actual radiotherapy. So this paper basically shows that radiotherapy following nasopharyngeal cancer results in a diminished actual olfactory bulb volume and deteriorates the olfactory function. Olfactory dysfunction is affecting the taste, is likely a contributing factor to lack of appetite, weight loss, and consequently quality of life in these patients. And then Dr. Patel has been doing research on olfactory training for the past 5 years. Initially started in Emory and then, brought her research projects over to here. So when she gave her first talk about this last year, I got really interested in the project. We sat down and talked about this, and we came up with this random screening trial regarding this study. So factory training is a very simple, non-invasive method in which patients actually smell 4 different commercially available odors for just 15 seconds each 2 times a day for a period of 12 weeks. Sounds pretty very easy and straightforward, right? So, and specific parameters, how close to hold to nose, how to breathe in, actually are not that important. It's been shown in another study done by Dr. Patel and Emory. And these are the papers, most of them coming actually from Europe. The guru of this project actually resides in Germany, which is the senior author of this paper, Dr. Hummel, most of these papers. So this non-invasive method has been able to improve olfactory function in patients with Parkinson's disease, post-infection olfactory loss, post-traumatic olfactory loss, idiopathic olfactory loss, with no significant side effects. And also they have some functional MRI studies that actually prove that the randomized clinical trial olfactory training actually helps these patients. You can see the recovery of olfactory function shown by fMRI. All right, so these are our primary outcome and secondary outcomes there. So the primary outcome is we're going to evaluate the effect of olfactory training, olfactory function in patients with paranasal, sinus, and nasopharyngeal cancers suffering from olfactory loss after radiation. And those are the secondary outcomes for RCT. So we evaluate the effect of olfactory training, olfactory ability, olfactory quality of life in patients with paranasal, sinus, and nasopharyngeal carcinoma, and suffer from olfactory loss after radiation. Also, we want to define rate and severity of olfactory dysfunction after radiation therapy in patients with deep paranasal sinus and nasopharyngeal carcinoma. And the other secondary outcome would be to evaluate the efficacy of olfactory training during radiation therapy to prevent olfactory dysfunction in patients with paranasal sinus and nasopharyngeal carcinoma. So this is a study design. It's a double-blinded randomized clinical trial with 2 arms. It's already approved by SRC, which for the people who actually own this committee, so they're like a group of people working in different area of oncology. They're based in Cancer Center, and it took about 8 months for the study to get approved. It's a pretty huge process. It's almost like, even more actually, like writing a core grant. So it's like a 40 pages, type of grant type of proposal that you need to put together, and okay, finally we get approval on IRB final review, and they're going to approve that on December 15th next week. All right, these are outcome measure tools. OPSIT is a very well-known, actually the most commonly used smell test in the United States. You're all familiar with that. I'm not going to go through all of this text there. Okay. But just briefly, it's a scratch and a sniff test with 40 multiple choices, forced choices question. Nice picture of that. All right. This is the other outcome measure tools that we're going to use. It's QOD, or question of olfactory dysfunction. It's the only quality of life outcomes test available for evaluating this important measure in patients with olfactory loss. So actually, it consists of 25 statements that are divided into 3 general domains, 17 negative statements, 2 positive statements, 6 socially desired statements. These are inclusion criteria. So patient with paranasal sinuses, malignancies, or nasopharyngeal carcinoma who are about to undergo radiation therapy. It's going to be our arm number 1. And the second arm, so arm number 1 is sort of like preventive arm, and arm number 2 is the therapeutic arm. So patients with paranasal sinuses or nasopharyngeal carcinoma who have already completed radiation therapy 3 to 6 months prior to enrollment who then show olfactory loss in screening tests. Those are the cutoffs for our excluding criteria. You have head trauma, nasal surgery other than biopsy in the past, whatever that confounds olfaction, chronic sinusitis, pregnancy, genetic dysfunction, history of brain surgery, psychiatric, neurologic issues, congenital disorders, olfactory dysfunction, olfactory loss prior to onset. Randomization procedure. So randomization of 1-to-1 anticipation will randomize by blocking techniques. They usually do not undergo surgery prior to radiation, as opposed to paranasal sinus cancer, will actually be randomized with stratified blood randomization work, because they actually do undergo surgery in most of the cases, which can play as a confounding factor. So that's the reason that we're going to use the stratified data. And those patient and investigator administered the OPSIT will blind as randomization. research treatment plan. So factor training group will use 4 specific essential orders as we discussed earlier per protocol. And the patient will be called by phone every 3 weeks during the study to check in and just to encourage compliance with the training procedure. We also ask the patient to keep a calendar mark of training every day, and we incorporate smartphone reminders if patients have this capability. And as we discussed, OPSI and QOD are main major outcome measure tools that we're going to measure at baseline and then after 12 weeks at the completion of the treatment. You can see parental science significant parts from arm 1 prior to radiation. We're going to enroll them, randomize them, control group, and a factor training group, and then we're going to measure the outcome measure tools again after 12 weeks at the end of the study. Arm 2, these are about the people who've already undergone radiation 3 to 6 months after radiation. Usual actual factor loss again, we're going to do randomize them, patients, controls, 12 weeks, outcome measure tools. So timeline. So because of factor training has never been actually utilized in this patient population, we do not currently know what person or patient, would show factor loss. So we're actually planning to, keeping the enrollment open for the initial 3 years. And then based on current number of patients who are treated at Cancer Center for NPC, we hope to enroll at least 30 to 40 patients per year.
So there's 30 to 40 new cancer NPC patients seen at Stanford every year? And how many have already had surgery?
NPCs, almost none. Paranasal sinus cancers, more than 90%. All right, before moving on to the next project, I'm happy to take questions.
What makes the cancer committee, what requires that particular body to review research? What type of,
If it's a cancer patient.
if it's a cancer patient, have to ask to go through that body? All research.
So if you opt for it to do cancer research, apply for that at least a year ahead. Definitely do that. Thank you. All right. Next project is another randomized clinical trial. Dr. Mose is a PI, and Dr. Samuel White has been wonderful helping me out with this project. So we're studying lateral we're studying actually lateral wall insufficiency, and we are comparing 2 different techniques to treat this condition. So nasal obstruction, as you know, is a commonly encountered, complaint in the otolaryngology practice, rhinology practice, facial plastic surgery, pediatric otolaryngology, and etiologies of these are actually many. But while the subtle deviation, chronic sinusitis, nasal masses, polyposis, all of these, diseases can actually do present with nasal obstruction. One should keep that in mind that lateral wall insufficiency actually does contribute to the nasal obstruction symptoms. A little background. So we're talking about internal nasal valve, historically external nasal valve. This has been changed over the past few years. So internal nasal valve is classically defined as area bounded by hollow edge of the upper lateral cartilage, nasal septum, anterior head of the inferior turbinate and nasal floor, whereas external nasal valve is formed by the hollow septum, medial coral, lower lateral cartilage, alar rim, and nasal seal. So the idea starts from this paper. Dr. Mose in 2008 actually coined the term lateral wall insufficiency in this paper. And then lateral insufficiency is classified by zone in which it occurs. You can see that depiction, what we're talking about. Zone 1 in lateral yaw occurs most cephalad and corresponds to dynamic movement of nasal side walls at the level of the upper lateral colchicine and scrotal region, also known as internal nasal valve. So zone 1. And then zone 2 lateral yaw occurs at the level of ALEX, more keen to classically describe external nasal valve. You can see that bottom picture. Also, there's a grading system validated by Gabe and Dr. Mose in 2013. This is a grading system, scheme for LWI. So in this grading system, basically movement of the lateral nasal wall towards the midline is noted for each zone 1, zone 2. And movement of the ball, 1% to 33% is graded as 1, 34 to 66 grade 2, more than 67 is actually grade 3. You can see All right, so a little bit about techniques. So these two techniques that we're going to use. Number one, lateral pull strut graft. You're all familiar with this technique. It's been described in 1907 by Gunter, one of the plastic surgeons in Dallas. We use open rhinoplasty approach. It's relatively easy procedure and technique, and you harvest the cartilage from either septum or pinna or the rib, and then you just put it basically under the lower lateral cartilage. Whereas the other technique actually has been, the modification of this technique also has been described by Dr. Mosi in 2007. It's a placement of lateral nasal suspensions to should be an external rhinoplasty approach. You see a depiction of that technique, and basically in this technique also you open up the nose, expose lateral cross and preform rim, and elevate the periosteum, and using the anchor suspension system actually you do the anchoring suture there. Inclusion criteria. So LWL age more than 18, failed prior medical management. They must be able, of course, to read, understand, and sign consent for exclusion criteria. Previous rhinoplasty, compromised active smoker, severe radiation, head and neck, septal perforation, granulomatosis disease, pregnancies. Methodology, it's an open label randomized clinical trial. We already approved this project. We've already started actually enrolling the patients. Randomization 1-to-1 again, and again we're going to use block randomization technique. Sample size, in order to get a power of 0.8, an alpha level of 0.05, standard deviation of 10, we need 17 patients each bar. We've already enrolled two patients. So hopefully by the end of, I have the timeline later. And the outcome measure tools are completed prior to surgery, 1, 3, 6, and 12 months after surgery. These are going to be our outcome measures. So number one is nose. Again, one of the most common and well-known outcome measure tools in the realm of rhinology and facial plastics. So developed in 2004 by Dr. Mickey Stewart, who was our guest speaker last year. This year, sorry, okay, 2004, and we're going to use it as a validated quality of life symptom survey composed of 5 questions that are assigned 4 points each, and the score is multiplied by 5. This is the second outcome measure tools we're going to use, visual-analytic scale, and the scale is a 10 centimeter horizontal line and board by board descriptors that you can see in the picture. All right, timeline. Oh, and also we are going to use actually the LWI grading system as we described before as the objective measure tool. So we have 2 subjective measure tools and 1 objective measure. And then our timeline, enrollments are started, enrollment to be completed in June 2016, follow-up to be completed in June 2017. So I'm hoping that I can present you in my 4th year. All right, and just briefly talking about the other 3 projects. So this is a retrospective review actually of a patient who already undergone LWR repair. And basically we are using the same outcome measure tools that we are about to use for a randomized clinical trial. So it's a retrospective cohort study, subject to undergo lateral insufficiency repair with different techniques, and nose questionnaire, LWI grading systems as outcome measure tools, and also the VAS visual analytic scale. We evaluate all of those before and after surgery, and this we've submitted the abstract because I haven't heard back yet. There's another one, Dr. Lee, working on endoscopic volume dilation of ET post-radiation, ETD. So Dr. Lee is actually the only one who does the balloon dilation in our department, I guess so. And this study is just to evaluate, for the first time, to evaluate the safety and feasibility and applicability of actually balloon eustachian tube, balloon eustachian tube plus in patient post-radiation type skin. It hasn't been described actually in the literature before due to concerns because of, okay, the radiated fuel, if you want to balloon that, it might be a risk to carotid artery, it might be just not easy. So our inclusion criteria includes history of recent head and neck radiation and persistent more than 3-month signs and symptoms of OMD. And we're going to use the eustachian tube dysfunction questionnaire ETD Q7 as the primary outcome tools. we already put together an abstract for our first 4 patients and submitted for trial in cause, and haven't heard back yet. This is the last one. This is almost a systematic review. I'm sorry, a comprehensive review and a new classification for a term which is called barosinusitis or sinus barotrauma. So we did a broad literature review that Patel and Narks, been my mentor in this project, and we did gather all the case reports, series, and everything that existed in the literature. We also proposed a new classification system that I'm not going to go into the detail. We also submitted for ARS